Good afternoon, everyone. Welcome to AFA's Care Connection webinar. This is Molly Fogel, the Director of Education and Social Services. We'll be going ahead and getting started in just about 7 minutes. We're waiting for a few more folks to get on, but we will be starting promptly at 1 p.m. Just so you know, a few housekeeping items. Those of you who are on the line, you're currently in listen-only mode. You'll remain in listen-only mode. More instructions will come as we get started at 1 p.m. Thank you so much for joining today. Good afternoon, everyone. Welcome again to AFA's Care Connection webinar. We'll be getting started in 5 minutes. Please note you are in listen-only mode. We'll be able to answer any questions as you can type them in on the right-hand side once we go ahead and get started in 5 minutes. Thanks so much for joining today. Good afternoon, everyone, and welcome again to the AFA's Care Connection webinar. We're going to get started in 2 minutes. We'll be getting started in 2 minutes. Thank you. Good afternoon, everyone, and welcome to AFA's Care Connection webinar. My name is Molly Fogel. I'm the Director of Education and Social Services for the Alzheimer's Foundation of America. This free and live webinar is for family and professional caregivers of individuals with Alzheimer's disease and related illnesses. And I would like to thank everyone for joining us today. We have a very special guest speaker, Catherine Thurston from the SPOP. She oversees the SPOP clinic in New York City, community outreach, and other program initiatives. She has over 29 years of prior experience in geriatrics, which includes serving as Chief Services Officer at SAGE, as well as the Director of Alzheimer's Program at the Cobble Hill Health Center. She also serves as adjunct faculty for the Silberman School of Social Work at Hunter College and has done that since 2016. Before we go ahead and get started with Catherine, I just want to orient you guys who may be new to this webinar. Just so you know, this webinar is being recorded, so if you miss a portion of it or your colleagues miss it, it will be on our website, www.alzfdn.org. Probably by Monday, it will be on our website and available for you to listen in on. Also, you are all in listen-only mode. So in listen-only mode, if you do have any questions, you can feel free on the right-hand side portal to type in any questions that you have, and we'll make sure to ask them to Catherine at the end of our webinar today. Also on the right-hand side portal, you'll see a section that says handouts. In these handouts, you will see today's slide deck as well as other materials that you may be interested in. So without further ado, Catherine, we are all ready for you. Thank you so much again for joining us today.
Thanks, Molly, and good afternoon, everyone. It's my pleasure to be here today to talk a little bit with you about depression and older adults. And I'm also going to talk about the agency that I work for currently and a little bit more about how that sort of intersects. So let me go back a slide. Service Programs for Older People, or SPOP, is the largest and oldest organization in New York City. We're located in New York City, dedicated to working with and on behalf of older adults and treating their mental health needs. Today we're going to talk about depression in older adults specifically, but the work at SPOP is broader than that, although depression is probably the most prevalent issue that we see amongst our older clients, and probably for those of you working in the field, the same for you. A little bit more about what we do at SPOP. Again, we're a leader in the field of geriatric mental health. We're one of the only agencies in New York City that is dedicated exclusively to serving the mental health needs of the elderly. And at SPOP, we define older adult as 55 years of age or older. And I'll talk a little bit more about that later on in the webinar. We currently serve over, actually this slide is a little dated, we currently serve over 1,200 older adults annually throughout the city. And our mission is to enhance the quality of life of older adults and to foster their independent living. And this is a very critical point through the delivery of comprehensive mental health and supportive services through advocacy and through education. So some of our programs. Our largest program is our clinic program. So we are what is called in New York City or New York State an Article 31 licensed mental health clinic. So we provide services to older adults in our main clinic on the Upper West Side and through 13 satellite clinics throughout New York City, all of which are located or co-located in senior centers. So our model is that we want to bring behavioral health and mental health services to the places where older adults are congregating. And that's for a variety of reasons, which we'll talk about a little bit later on in the webinar regarding the importance of destigmatizing mental health and mental health needs for the older adult population. We also have a very unique service at SPOP in that we provide mental health, and when I say mental health, I'm talking about licensed clinical social workers providing therapy as well as psychiatry and psychiatric services and medication to older adults who are homebound. And that really is a very unique service to SPOP in that for older adults who are no longer able to access mental health treatment in clinics, in traditional clinics, because they are homebound, and they can be homebound due to medical reasons, they can be homebound due to psychiatric or emotional reasons. We will treat them in their homes. I mentioned that we have our satellites throughout New York City, and we also have a program called PROS, or Personalized Recovery-Oriented Services. And PROS, for those of you who have been working in the field, is really the evolution of what used to be called continuing day treatment. So the PROS model is a model that specifically targets and serves severely and persistently mentally ill people, and SPOP operates the only geriatric PROS program in the state of New York. We also provide, and today is a perfect example, education and training. We at SPOP feel like we sit at the intersection of mental health and aging. And so we feel it is really part of our mission and our role to help train people who are working in the aging network to help understand behavioral health, how to work with older adults who are suffering with mental illness. And on the same time, we try to help the mental health network understand what is different and unique about working with older adults. And so we provide education and presentations nationally in New York City to providers to help them improve the work that they do in both of these areas. We also provide substance abuse support to older adults who have a co-occurring disorder of a substance use issue. And we're going to talk a little bit about that in the webinar when we talk about some of the co-occurring disorders that accompany depression. And finally, we provide support to bereaved people through our bereavement support program. We have grief and bereavement groups that operate throughout the year, and they are co-facilitated by people who themselves have been bereaved. So they're not run by social workers. They're true support groups that are run by volunteers that are supervised and trained by our social work staff, and those groups are free. And finally, we offer caregiver support to older adults who are either receiving care or are helping to take care of someone that they love. And unlike a lot of the other caregiver support programs that are out there, and there are some fantastic programs out there, SPOP's focus for caregivers is on the mental health needs of the caregiver. Okay. So a little bit about aging before we talk about mental health and depression specifically. And these are facts from the World Health Organization. So between 2000 and 2050, the proportion of the world's older adults is estimated to double from about 11% to 22%. This is an expected increase from 605 million to 2 billion people over the age of 60. You know, we all talk, certainly those of us who work in the field of aging, about the graying of the baby boomers and the age tsunami and all the different terms that are out there. But I feel like this figure, 2 billion people over the age of 60 by 2050, is really a stark reminder that services and delivery needs to really get ready for the enormous number of older adults that we're all going to be dealing with. And some of us are going to be among that age group. Approximately 15% of adults aged 60 and over suffer from a mental disorder. So when you think about that number, when you think about 15% of adults age 60 and over, and you think about the fact that that number by 2050 is going to number in the billions, we're looking at really an enormous mental health crisis if we are not, as professionals and as caregivers, ready to handle that. So some common myths about aging. And this one, the first one, is particularly relevant to today's conversation. Depression is a normal part of aging. And we will get into that, but I think most of you know that depression is not a normal part of aging. Any cognitive impairment is a sign of dementia. Again, that is also a myth, and there are many other reasons that people may exhibit or demonstrate cognitive impairments, and depression is certainly one of them, and we'll talk about that in a little bit. Another myth about aging is that older adults do not misuse substances. Certainly for those of us here at SPOP who are working with older adults with co-occurring disorders, we know that is not the case. Many older adults are also users of substances, sometimes because they were substance users in their youth and they continue to exhibit those behaviors as they age, and sometimes because they turn to painkillers or alcohol to help mask either physical pain or emotional pain that they're experiencing as they age. Another myth that we hear a lot is older people won't benefit from therapy. You can't teach an old dog new tricks. And that absolutely is not the case, and some of our outcomes that we'll talk about in a little bit certainly show that. And another myth that I certainly have heard a lot, I spent many, many years working in the LGBT community, and one of the things I often heard is that, why do you need to have special programs for LGBT people when older people aren't having sex anyway? Again, another common myth about aging. Another barrier, besides the myths that are out there around connecting people to care, is the reluctance that so many people have to ask for help. Many people don't understand and even don't believe in mental illness, right? I can take care of this myself. This is something I'm just going to get past. I'll handle it on my own. I always have. Some older people are frightened by their symptoms, or, as we mentioned earlier, think that they're a normal part of aging. Loved ones or even doctors may fail to recognize the symptoms of treatable mental illness. And we're going to talk a little bit about how physicians and doctors play a role in helping older adults grapple with and deal with their depression. People are often ashamed to ask for help due to their culture's expectations of autonomy or privacy. This is certainly something that we see here in New York City, where we work with people from a myriad of different cultures and ethnic groups, and so many of those groups have very, very deep feelings about mental illness, and a lot of shame around the possibility that they or a family member might be afflicted with a mental illness. People who are already marginalized, whether it be by disability, sexual orientation, gender identity, racial or ethnic minorities, may not want to risk double or triple stigmatization. And what that means really is that as an example, someone who identifies as an African-American lesbian may already be feeling incredibly stigmatized from a variety of different vantage points and intersections, and the idea of coming out as mentally ill might feel very, very challenging. So, what does that all lead to? It leads to, how can we help people who are suffering be brave and lead them to the treatment that they need? And specifically today, we're going to talk about treatment for depression. Depression is the most prevalent mental health problem among older adults. And again, think back to that earlier statistic about the numbers of older adults that are currently in the world and will be in the world. And then think about what that looks like when you look at the numbers of people who may be suffering from depression. Of the 35 million Americans aged 65 and older currently, about 2 million are suffering from full-blown depression. And another 5 million are suffering from less severe forms of the illness. And while these forms may be less severe, and we're going to talk about that in a moment, what those different forms can look like, that's 7 million people who are suffering from a disease that is treatable, and in some cases is preventable. So what are some of the complications of depression? Depression can lead to impairments in physical, in mental, and in social functioning. Depression often adversely affects the course and complicates the treatment of other chronic diseases. And this is an especially critical point when you're talking about depression among older adults, many of whom will be suffering from what we call comorbidities, other diseases of aging, whether they be dementia, and we will talk about that in a moment, or other physical illnesses. Right? So depression can obviously or can often adversely affect the course of someone's medical condition or their cognitive condition as well. Again, the silver lining to all this is that depression is one of the most successfully treated illnesses. We mentioned earlier one of the myths, right? Depression is not a normal or inevitable part of aging. Right? And understanding that and helping other professionals and other people in the world understand that is a critical first step in helping to treat the issue. Another thing that we know is that depression in older people is often unrecognized and undertreated. So why do we think that geriatric depression is so underdiagnosed? And we're going to explore each of these a little bit more deeply as we move along in our webinar. One reason is that medical conditions may mask depression. Okay? So some of the diseases, some of the physiological diseases out there may have symptoms that are similar to depression, and very often physicians go to is to look for the medical causes. Older adults are often more likely to complain to doctors about their physical problems than about their depressed mood. I would even go further and say that for many older adults, sometimes even talking about their physical problems with their physicians is challenging. People are often intimidated by their healthcare practitioners. When I worked in sexual health, one of the things I learned is that older adults have a very difficult time talking about sex, safe sex, their sex lives with their doctors, frequently because their doctors did not know how to raise those questions, did not know how to start the conversation. And the same can be said for many physicians, and this is a generalization because there are other physicians out there that are very skilled in doing this, but many physicians or healthcare practitioners don't ask questions about their patients' emotional lives. They don't ask, or they don't go deeply into how someone might be feeling other than how they're feeling physically. And for people who are already feeling shame or are already feeling fear around their own concerns that they may be depressed, it doesn't create an environment that's conducive to having dialogue. As we mentioned, another barrier is that symptoms of depression may be considered normal signs of aging, right? I've known physicians to think that people who are sleeping for longer periods of time or sleeping for less periods of time attribute both to, well, that's what happens when you get older. You need less sleep. You need more sleep. You get out less. You do less. You have fewer friends. That's all normal because you're losing your cohort. Well, it's not normal. And many of these symptoms are really red flags that somebody is suffering from a depressive disorder. Finally, cognitive impairment may complicate diagnosis of depression. This is absolutely true, and we're going to talk a little bit more deeply about the differences between dementia and depression as we move along in the webinar. So, what is depression, and what does it look like? In its most basic form, depression is sad or irritable mood with physical or cognitive changes that make functioning very difficult. Again, this is a very broad definition and covers a lot of different symptoms, which is why it's so important for people to be attuned to the possibility that something that's happening to a patient or a client is actually depression. Depression can be feeling so bad that you cannot move or motivate, right? That even the smallest thing is almost impossible, feels physically impossible, whether it's to get out of bed, whether it's to go to your doctor's appointments, whether it's to continue to go to the senior center that you've been attending for years. It just feels impossible to make a move. And depression can be having no ability to anticipate pleasure or happiness. I want to say this one again, having no ability to anticipate pleasure or happiness. One can only imagine what a bleak and terrible place that must feel like for someone who is suffering from that kind of depression, that there's nothing that they can think of that will bring them any pleasure, even things that brought them pleasure in the past. So let's talk a little bit about the signs and symptoms of depression in older adults. Depressed mood for most of the day. So one of the challenges about talking about depression is that the word depressed is a disease entity, it's an adjective, it's a verb, it's a very, very broad term. And I think sometimes we can underrepresent or overrepresent what depression looks like. But a depressed mood for most of the day means that somebody really is feeling suppressed. They don't feel their feelings the way that they used to. And they're really feeling flat. And most of their day feels like that. They may have moments, maybe early in the morning when they first get up and they have more energy, maybe later in the day when they get a phone call from a family member where they feel a little bit better, but they report that for most of the day, their mood is flattened or low. They have a diminished interest or pleasure in activities. Again, somebody who used to love to play golf, who used to love to spend time with their grandchildren, who used to love to volunteer. Even if they're still doing some of those things, they don't have the same pleasure and the same kind of happy anticipation about doing those things as they used to have. Significant weight loss, again, without a physiological component, or weight gain are both signs of depression. Now, again, if somebody is trying to lose weight or trying to gain weight, then those are not applicable symptoms. But if someone is not trying and their patterns haven't changed, or if they're eating all the time and they don't know why, and this is not something that they have struggled with in the past, this could be a sign of depression. As I mentioned earlier, insomnia or hypersomnia, both of these, sleeping all the time, not being able to motivate, or not being able to sleep even though you're exhausted, are both signs of depression. Recurrent thoughts of death. So if somebody is really unable to break that thought cycle, that thought pattern, and the idea of dying, whether it's their own death, whether it's the death of people close to them whom they love, is something that continues to cycle through their brains throughout the day, that is a sign and a symptom of depression. Psychomotor agitation or retardation. Again, one of the challenges of depression is that it's really a very black and white disease. And so you can be extremely agitated and kind of nervous and feel the need to walk all the time. Or you can feel, as the next bullet states, a kind of lethargy, a loss of energy, not really feel like moving your body. Both of those things can be a symptom of depression. Fatigue is a very common symptom for people who have not felt fatigued in the past. This kind of malaise or loss of energy where really nothing motivates you is a very, very common and often heard symptom of depression. Feelings of worthlessness or excessive or inappropriate guilt. And again, these are the kinds of symptoms that you will only get to if you really engage in a deep dialogue with your loved one or with your client about how they're feeling, right? Because these are not normally the first presenting problems or the first presenting issues. If you dig a little bit deeper and find that someone who normally or in the past had good self-esteem and did not suffer from excessive guilt is now starting to feel that way, that is a red flag. Diminished ability to think or concentrate, or indecisiveness in someone for whom that was not a pattern in the past is also a sign of depression. So now we're going to talk a little bit about the DSM-5 for those of you who are working in the field and how the DSM-5 can be a helpful tool in diagnosing depression. For those of you who don't know what that is, the DSM-5, it is the Diagnostic and Statistical Manual, the 5th edition, and that is really sort of the kind of Bible for mental health practitioners in terms of it's a book that defines clusters of symptoms and behaviors into diagnoses, and those diagnoses are used to categorize, to define, to diagnose, but also to bill for people who are being seen in licensed mental health settings. Having a diagnosis directly leads to the ability to bill insurance companies. So major depressive disorder is probably the most serious and the most common, or the first thing that one thinks of when they think of a DSM diagnosis around depression. And the DSM is really a cluster or a list of symptoms, And when you are working with someone or trying to diagnose someone, the number of boxes that they check off in that sort of list of symptoms helps to define their diagnosis. So for major depressive disorder, it's at least 5 of these 9 symptoms, and that symptoms are persistent and that they are either mild or moderate or severe. Feelings of worthlessness and self-loathing are common, as opposed to grief, which is characterized by emptiness and loss. There is also a diagnosis that is called persistent depressive disorder, also called dysthymia, which is really kind of a longer onset and term of depression. 2 out of the 9 symptoms need to be met in order for that diagnosis to make sense, and it's persisting for 2 years or longer and often has an early onset. So that is a diagnosis that you may find in someone who's been struggling with depression throughout their life cycle. It is not something that started at an older age. It's something that they have been struggling with and have never really been able to move away from in their life. As I mentioned earlier, there's also a substance and medication-induced depressive disorder, which is when symptoms develop during or soon after exposure to substance. And the depressive symptoms are primary. They're stronger than the effects of the intoxication, right? And that can present with the use of alcohol, hallucinogens, opioids, sedatives, or stimulants. Right? So it's very important to get a good substance use history from the people you're working with in order to ascertain whether their depression might be related to their substance use. Depressive disorder due to another medical condition are depressive symptoms that are also called a direct pathophysiological consequence of another medical condition. It doesn't mean that they're having an adjustment disorder. Right? So the difference between an adjustment disorder, so you're diagnosed with a disease like Parkinson's, like Alzheimer's, and you have an immediate reaction to that, and one of those reactions is depression, which is a very common reaction to getting a diagnosis like this. Depressive disorder due to another medical condition is not a short-term limited adjustment that you work through. It's a direct result of this medical condition. It's a physiological result of your medical condition like HIV or AIDS or dementia or metabolic conditions. Those conditions are actually causing the depression. Then we have what is called other specified depressive disorder and unspecified depressive disorder. Most of the diagnoses in the DSM have an unspecified category because there will always be people who do not check off the boxes. There will always be people who are exhibiting clearly clinically significant distress and depression, but they don't meet one particular diagnosis threshold. But you as a loved one or you as a professional in the field recognize that this person is depressed. Then there are also people who have a major depressive disorder and they exhibit psychotic features. And that is a depression that also comes along with hallucinations and delusions. And people with a major depressive disorder present with hallucinations and delusions in almost 20% of the cases. And that is particularly relevant for those of us who are working with folks with a cognitive impairment because that can get misdiagnosed as dementia. So it's important to recognize that some people with no cognitive impairment will demonstrate delusional behavior or will speak to hallucinations when they're actually experiencing a very, very major depressive disorder. So depression or dementia, and I think this is a critical question that all of us working in aging need to have a little bit of understanding around in order to best serve our clients. So I'm not going to read this slide, but you guys can all take a look at it and basically recognize that, you know, the difference really is that somebody has a context, right, for their question and somebody doesn't, right? There's a deeper kind of confusion and disorientation that results from someone who's suffering from a cognitive impairment than the kind of confusion that we normally see in a major depressive disorder. So let's look at those a little bit. Depression. What we tend to see is that mental decline is relatively rapid. right? When somebody goes into a depressive state, they go from being oriented to not being oriented fairly quickly. With dementia, generally speaking, and again, these are generalities, but generally speaking in dementia, mental decline happens slowly over a longer course of time. Now, of course, this depends on your actual diagnosis, but for Alzheimer's type and for sort of the dementias that are related to strokes, that tends to be the case, right? In depression, people with depression, if you are giving them a mini mental status exam, they tend to know the time and the date. They are oriented, ×3, right? Their disorientation shows up in very different ways. For the most part, when you are providing or doing a mini mental status exam with somebody with a dementia diagnosis, they're disoriented to time, to place. They become lost in familiar locations, whereas that's not the case for somebody with depression, right? Somebody with depression may feel disoriented and may feel very, very sort of disengaged from their normal self, but they are able to find their way home, for example, from the doctor's office, or they recognize the people in their lives. In depression, what you see is a difficulty concentrating. That's a really common symptom, that people really are just feel unmoored and have a hard time focusing. Whereas with dementia, what we are more likely to see, especially in the earlier stages of dementia, is difficulty with short-term memory. People with depression often, their language and motor skills might be slower. They're slowed down, especially people who are having a major depressive incident, but they're normal, right? They don't lose their ability to speak. They don't lose their ability to walk, but they're slowed down. Their psychomotor skills are retarded. Whereas with somebody with dementia, generally speaking, especially as you move along the pathway, their writing, speaking, and motor skills are impaired. Somebody with depression notices or worries about their memory problems. Somebody with dementia, and there's a caveat at the end of the sentence, somebody with dementia doesn't notice memory problems or seem to care. That is true at the middle and later stages of the illness. I did spend more than a decade of my career as the director of an Alzheimer's inpatient residential unit. I have a lot of experience working with people with dementia, and I know very well that people at the early stages of a mild cognitive impairment do notice and do worry and do become depressed. And that is why a differential diagnosis can be so complicated when working with people at the early stages of dementia, because in that case, some of these symptoms do overlap and intersect. Some of the specifiers in the DSM-5, and I'm going to go through these quickly. You can also have depression with. So a specifier means a little bit of a kind of specific add-on that really showcases what your particular client or patient is going through. So somebody can be depressed with anxious features, right? Being depressed does not mean that you can also not be anxious and be in distress. You can be depressed with mixed features, meaning that you can be depressed, but you can also be very manic. You can exhibit symptoms of mania, where you are hyper energetic and hyper excited, and that looks a lot like a bipolar disorder. You can be depressed with melancholia, which is really a severe stage of the depressive episode where there is such an intense sadness to your mood that it's more than just a dysthymia. You can have a single episode of depression, or you can have recurrent episodes of depression. There certainly are people who have a single episode of even a very, very deep depression and are treated and never experience it again. And there are others, including people who've been suffering their whole lives, but older adults who may experience depression and then it becomes a kind of episodic and recurrent experience for them. We mentioned bipolar disorder. So these are some of the other diagnoses that are connected to depression. If somebody has at least one manic episode in their lifetime where the symptoms last longer than 7 days, then their diagnosis is usually not depression. It's usually considered a bipolar disorder. Major depressive episodes are common in bipolar disorder but are not required for this diagnosis. Bipolar 2 is a little bit different in that at least one hypomanic 4-day episode and at least one major depressive disorder episode needs to be evidenced. So how do we screen for depression? If we know that this is such such an enormous issue for older adults, and we know that it is so often underdiagnosed. How can we screen? One of the screening tools that is very, very frequently used, at least in New York City and New York State, is something called the PHQ-9, or the Patient Health Questionnaire. It's an evidence-based tool. It is free to use. It is downloadable, and it's self-administered by patients. And so for all those reasons, it makes it a very user-friendly tool, and is frequently used by social workers and practitioners to sort of get people not just to screen them for depression, but to help open up a conversation, which is really what every screening tool should do for us, help open up a conversation and a dialogue about how your client is feeling at this very given moment. So in terms of the scores reach through 20. Somebody who scores a 5 through a 9 on a variety of questions, right? And the questions are very related to the symptoms. How are people sleeping? How are people eating? How are people in their thought process? Are they thinking about death? Really, they directly relate back to the DSM cluster of symptoms that would identify somebody as being depressed. And then you are able to score. If somebody scores between a 5 and a 9, their symptoms are really minimal. And what we want to do is provide support and psychoeducation. Even if somebody is not depressed right now, it does not mean that they're not at risk. And so we want to give people a little bit of understanding of what depression looks like and what they should watch out for. Somebody who scores a 10 to a 14, we would consider having a minor depression or a dysthymia. Watchful, we should be watchful. We should be waiting to see if that really develops into something a little bit deeper of a major depression. And psychotherapy is indicated at a score of 10 or higher. If someone scores a 15 to a 19, we would consider that to be a major depression. And we would certainly encourage psychotherapy, but we would also want to talk about pharmacological therapy and talk about medications with somebody who is scoring 15 or higher on a tool like a PHQ-9. 20 and higher, we would consider major depression, right? This is somebody who has told you that they think about death all the time, that they don't sleep or they sleep all the time, that they're not eating or they're eating all the time. They're really checking off every red flag they can possibly check. And in a case like that, we would certainly want them to be engaged in treatment, in psychotherapy. We'd want them to be looking at medications. We might even be looking at things like ECT or treatments that are a little bit more medicalized. So what are some of the risk factors for depression in old age? One of the risk factors is being female. Females are much more likely to exhibit symptoms of and to complain about feeling depressed. A chronic or a disabling illness is often a precursor for depression for understandable reasons. A lack of social support, right? People who are aging in isolation are much more likely to exhibit signs and symptoms of depression. Recent loss, obviously, people who've been bereaved are experiencing recent losses, and the losses don't have to be death. They can be the loss of role, somebody who has been a caregiver for a long time and they are now no longer a caregiver, somebody who defined themselves by their work and were really deeply engaged in their professional lives and is now retired and feels completely unmoored, can feel that's the loss that triggers the depression. And obviously but very often a prior history of depression can be an indicator that somebody is going to experience depression in older age. So this is a quote from one of our participants at SPOP that I really feel it just moves me every time I read it. Being depressed is like wanting to get away from this world, wanting to lose oneself in sleep, waiting for the end of the day when you know you are going to sleep and don't have to think about it anymore, missing the things that you're used to and not really enjoying whatever is left, just pushing through. So that really speaks to some of the things that we talked about a few minutes ago regarding sort of this inability to feel joy or happiness, and really things that brought you pleasure no longer bringing you pleasure. I want to talk a little bit about the risk of suicide, because when we talk about major depression, that's something that comes up frequently. Older Americans are disproportionately likely to die by suicide, and people aged 65 and older account for 16% of suicide deaths. and 14.3% of every 100,000 people aged 65 and older died by suicide in 2004. The highest risk group are non-Hispanic white men age 85 and older. Highest risk group to die by suicide are older white men. So some common myths about suicide. If someone is determined to kill him or herself, no one can stop it. Those who commit suicide do not seek help before their attempt. This is something I hear frequently, that I don't want to ask my client about suicide because if I ask them, I'm going to put the idea in their heads and it's going to lead them to kill themselves. That is a myth, and no one has ever been talked into. I've never had a client or ever heard of a client who said, I never thought about that before, but now that you mention it. So talking about suicide and bringing it into the light is actually what we need to be doing. And those who talk about suicide rarely actually do it. That's also a myth. Some of the risk factors for suicide in later life. Again, we mentioned being male. Right? Women are more likely to be depressed. Men are more likely to be a high risk for suicide, death by suicide. Older age, bereavement, again, especially in men. Social disconnection, again, so much of social isolation speaks to depression and suicidality, which is really the importance of social connectedness. Psychiatric illness, the misuse of alcohol and other substances are also risk factors. Physical illness and a previous suicide attempt is also, like a previous depressive episode, a red flag. The most significant predictor is expression, people talking about it. That is the most significant prediction. We have to pay attention to what our clients and our loved ones are telling us. Some of our warning signs, again, a lot like the warning signs of depression: loss of interest in formerly enjoyable activities, cutting back on social interactions, on self-care, breaking medical regimens, refusing to eat, experiencing loss, feeling hopeless, putting affairs in order, giving things away, right? And stockpiling medications or other lethal means. This is a critical thing for us to look at with our clients if they have a plan and they have a means. In the interest of time, I'm just going to move through these a little bit. So some of the treatment modalities. Obviously, individual psychotherapy is probably the most prevalent and the most successful in working with somebody with a depressive disorder. But group psychotherapy, especially for folks who are experiencing dysthymia or a longer term or a recurrent depression, can be very, very, very successful. People who have a new episode or a really deep onset of depression will probably respond to a combination of individual psychotherapy and medication management the most positively, but moving people through into groups where they not only have an ability to hear other people's stories and to help validate their own, but then that also speaks to the idea of social connectedness and reducing social isolation as being a treatment, right? And being a prevention method for depression and mental illness, connecting people to each other. Some of the outcomes of treatment: increased self-efficacy, decreased helplessness. We give people the tools to treat their own depression. We give people the tools to identify when they're starting to feel sad and hopeless. Improved physical health, right? People's self-care improves. Their connection with their healthcare providers or alternative health options. One of the things we hear all the time is, I'm too depressed to go to the doctor. I'm too depressed to, take care of myself or take a shower. So as the depression is alleviated, all these self-care methodologies come back into play, right? Improved ability to cope with stress, not lose stress. And I think that's a really important point. We do not want to offer people promises that we cannot keep. None of us in our lives have no stress. None of us in our lives have no sadness. But what we can teach people through psychotherapy is how to cope with those symptoms, how to help alleviate to the best of their ability these symptoms, and how to recognize them when they start. Right? If somebody experiences cyclical depression, what are those warning signs and what can you do? What kinds of treatment tools can we come up with to help you so that you can stave them off to the best of your ability? Another benefit of treatment is that there's a decrease in symptom disturbance or a decrease in symptoms. Sometimes it's decreasing your symptoms, and sometimes it's decreasing how those symptoms disturb you, right? You know, somebody might be immediately triggered by a night of insomnia and think that they are going to go back into a spiral of depression. With therapy, we can help people understand that nights of insomnia are going to happen and they're normal, and that does not mean that you are going to become depressed again. It means that you have to use some coping strategies to deal with those nights when you're not sleeping as well. How to talk to your client about a referral for mental health treatment. Right? We have to normalize and express concern at the same time. Help people understand that this is not unusual, but it still is something that you need to treat. And that's a critical sort of intersection. Just because other people feel it doesn't mean it's normal, but just because you're feeling it doesn't mean it's not normal. Right? And so sort of helping people understand both sides of that. Destigmatizing mental health treatment is critical through psychoeducation, through workshops, helping people understand how important mental health treatment is and how pervasive mental health issues are in the world, how many people are struggling with this. Really helps people feel less alone. And focus on the goal and the outcome that the client wants. So rather than focus on the depression, focus on what would you feel like if you were not depressed? What could you be doing if you were not depressed? Really make this sort of an aspirational process with clients and help them understand that if you get through this, this is what we want you to feel like. And finally, this is just some information about SPOP and how to make a referral. As Molly mentioned, these slides are going to be available, and my information and the intake director's information will be part of that slide deck, so you can certainly reach out to us directly, not just with referrals, but if you have other questions. And although we are in New York City, we also partner with national organizations all over the country, so if you're located somewhere else, that would be fine for you to give us a call, and we can try to connect you with a provider in your area.
Excellent. Great. Thank you so much, Catherine. We already have a few questions for you. And just as a reminder to those folks who are listening in, on the right-hand side portion, you have an opportunity to type in any questions that you have for Catherine regarding her presentation as well as just her expertise. So the first question came in from Risa asking about would a stroke qualify as a medical condition?
Oh, absolutely, absolutely. And it's very, very common for people to exhibit symptoms of depression post-stroke, especially if their physical condition has been affected by the stroke or their memory has been affected by the stroke. So absolutely.
Great, thank you. And so again, for folks who are just listening in or looking to write a question, you can type a question in on that right-hand side portion. There's an opportunity for you to write out your questions. Catherine, we've got another question for you in terms of how do you work with a partner system, so a husband and wife or significant others who are, where one person is noticing the other person is having some mental health concerns but not willing to talk about it. How do you help that unit? What are some strategies that you have?
That's a really great question. So one of the things that I did not mention is that the mental health services that we provide at SPOP are voluntary, which means that people have to want to be engaged in treatment and have a goal for treatment. So in the case of someone who recognizes that the person that they love is experiencing depression, there really is no way to force somebody into treatment. The best approach would be, well, there's a couple of things. First of all, if, let's say we're talking about a husband and a wife, and the husband is depressed and the wife is noticing it. The wife, one thing that we often recommend is that they model what they want their spouse to do or their loved one to do. So they engage in treatment, right? They go to a group. They start to talk about their feelings in order to make it a little bit safer for the other person to do the same. The other thing is to, if you are a part of a senior center or part of another congregate group, attend psychoeducational workshops together where it doesn't feel as threatening, right? You might want to stop into a depression around the holidays presentation with your loved one where you get to listen to somebody talk about all the things that I talked about today, and sometimes that helps normalize for the person, you know, this is something that other people experience. Maybe it wouldn't be so bad for me to talk to someone about my feelings, but it often is kind of a long process to bring someone to the place where they feel ready to talk.
Excellent, great. And so I love what you're talking about in terms of the psychoeducation, and even this webinar perhaps is something that you can share with family members to get a little bit more of an understanding and education. Additionally, whether it's calling the folks at SPOT for support or calling our national toll-free helpline here at the Alzheimer's Foundation, we're certainly here to help you have these conversations with the people that you're here to work with. Great, thank you so much. We've got a few more questions. This one comes in from Risa. Is Zoloft a medication that helps with depression? Who or what symptoms suggest that it would be helpful?
So, Rita, that's a great question. I am not a psychiatrist. So Zoloft, yes, Zoloft is an antidepressant. There are very many categories of antidepressant medication out there. And a prescriber, so either a psychiatric nurse practitioner or a psychiatrist, are really the best people to answer those questions. It's a little bit more complicated with older adults because they are so often on what we call polypharmacy. They're on many, many medications at the same time. So it's very critical that if you are working with someone who's depressed and we think medication might be indicated, either because of the score that they got on the PHQ-9 or because they're very depressed, and traditional psychotherapy isn't enough. It's very important for all of their medical practitioners to communicate with each other. So our psychiatrists, for example, they always speak with the general primary care doctors of our patients to make sure that whatever they're prescribing isn't contraindicated with another medication.
Excellent. And I'd like to add to that, if I could, you do want to be mindful in terms of what we talk a lot about in terms of dementia-related illness and Alzheimer's specifically, is ensuring that is this to treat a behavior or a symptom, and to make sure that you're working with professionals who are aware not only of the mental health condition, but how Alzheimer's may present within a person. They're aware of diagnosing the person and understanding both the co-occurring conditions that could be happening, as well as the psychopharmacology, the dosing, and all of that other good stuff. So make sure you've got good psychiatrists that you're working with and clinicians that you're working with. Excellent question, Risa. More questions. So Naomi is asking, for an elderly client, is it better to use the PHQ-9 or the geriatric depression screening tool?
Another great question. I'm a fan of both, to be completely candid, the reason why the PHQ-9 is the tool that we use here at SPOP and most of the New York City providers that I work with use is because that is what our regulating agencies, so the Office of Mental Health and the New York City Department of Mental Health and Mental Hygiene, ask us to use those tools. So sometimes your tool is kind of given to you by the funder or by your regulatory agency, but I'm a fan of both of those tools. The PHQ-9 is shorter, and again, it can be self-administered, although it doesn't have to be. I should say that if you have a client that, really you don't think for a variety of reasons can do a self-administered version, you can ask those questions yourself. But I don't think one tool is better than the other. And I also think that the tool is only as good as the person who's asking the questions. So if you're delivering the questions and starting a dialogue based on those questions, either tool could really work.
Excellent. Great. Thank you so much. Great question, Naomi. Question here coming from Marcia. What recommendation can you give for an older adult who lacks informal support or family, is not much involved in care, is depressed, and lives alone?
Oy, that is not a question. That's a whole other webinar. That is extremely challenging. I mean, there's so much more that I would need to know, and I don't know if you are working in New York City or living in New York City, and it's something we could talk about offline. But it is, one of the biggest challenges of any aging provider is working with someone who's very, very disenfranchised, someone who's alone, someone who doesn't have supports. There are some terrific case management agencies in New York City that provide in-home sort of concrete support, and sometimes that's really what you need to do is kind of assess through the hierarchy of need. Do they have shelter? Do they have food? Do they have the basics? And if they do, then the case management agencies can build a relationship with an older adult and then sort of work to bring in services like SPOPs.
Excellent. Yeah, and I think, Marcia, that's like Catherine's saying, that can be so involved. AFA actually has an isolation and aging presentation that we provide here in New York City. We'll be doing it in Brooklyn at the end of January if you are local. We are looking to see if perhaps we can put that into a webinar because it is such a loaded topic. So we do want to make sure that that if you have those particular questions in terms of informal support, and whether it's you're here in New York and want to check with the folks at SPOP, or you're more than welcome to give our helpline a call and we can troubleshoot with you and find you resources in your local area. So Marcia, that's also an option for you. Thanks so much, great question, and feel free to reach out to myself or Catherine or any other provider in your local area to assist in kind of troubleshooting that issue. Kendra has a question asking if your services are free.
Good question, Kendra. So our services we bill insurance. So we are a medical service, the way going to the doctor would be. So because we're a licensed behavioral health clinic, so we would bill somebody's Medicare or their Medicaid or their third-party insurance. So people do not have to pay out of pocket, with the exception that Medicare, many Medicare plans have a copay for behavioral health. And we would charge the copay, but we also have a sliding scale for people who don't feel that they can afford that.
Excellent. Okay, great. Thank you so much. So Carmen has a question, and Carmen is here in New York City. She's asked, how do you join a support group for someone who is dealing with a parent who is depressed and shows sign of dementia? She denies that she's forgetting things.
Molly, that might be a better question for you.
I'm happy to take that.
Piece. Yeah.
So Carmen, we have here at AFA, we have virtual support groups over the phone, and they are free. So that way you have an opportunity to receive the support that you need weekly. Our support groups are facilitated by licensed social workers. So we have one on Monday and a new one starting on Wednesday. So you can give us a call or email us, and I can give you more information about that. If you're looking for other support groups, there are a variety of different ways. If you want to go through something like a NAMI, or National Association of Mental Illness, they may have support groups that could assist for folks whose parents are living with the illness. A general support group could also be found in a variety of different hospitals. If you're looking for an in-person support group as well, you can find those here in New York City with a variety of different vendors, whether it's in university-based hospitals, whether it's through something like the Alzheimer's Association or Caring Kind. And as I mentioned, here at AFA, we have those phone-based support groups, which are free for you. And I'm happy to go through it and give you a little bit more information, Carmen, if you wanted to reach out to us. I think, Catherine, if you could go to the next slide, it has our helpline number as well as our email address. And then we have a few more questions. I think we've got about 5 more minutes. So the next question comes from Ernest. How long are the treatments that you're providing, Catherine?
That's a really good question. So how long the treatment lasts depends on how long it takes somebody to meet their goals. So everybody has a goal for treatment, and maybe your goal is, I want to be less depressed. I want to feel good about seeing my grandchildren. I want to not be so unmotivated, and you articulate these goals, and then you work with your therapist to meet them. And sometimes that can take 6 months, sometimes that can take 3 months, and that can take 2 years. So we don't have time-limited treatment. We don't like to keep people in treatment forever because we don't find that's really helpful. But again, the idea is that the treatment revolves around what your goals are and what getting better looks like to you.
Excellent. Great. Thank you so much. A few more questions. Do you provide home visits?
Yes. So we do provide home visits throughout Manhattan. We do not provide home visits outside of Manhattan, although we can take clients from any of the 5 boroughs if they come to our satellites. So we will provide weekly psychotherapy and psychiatry services to older adults who are homebound.
Excellent. And then, yes, Kathy had the same question. Is your agency providing in-home counseling?
Yep.
Okay. And then there are a few other questions regarding some of AFA's programs and services in terms of do we provide services in other states? And just so those of you who are on the line and might be new to us on the line, we are a national organization and we do provide our services around the country. We have a lot of virtual programming, including these Care Connection webinars, which are held on the 2nd Thursday of every month. The next webinar is actually going to be January 11th, which will be called Supporting the Well-Being for a Person with Dementia and Their Care Partner. So please make sure that you tune into that. We also have a 6-hour training program that's available on DVD or live in our classroom here in Manhattan. We are located in Chelsea, in the Chelsea neighborhood of Manhattan. And the DVD, which is 6 hours long, provides a comprehensive understanding of everything you need to know to be working with an individual who's living with a dementia-related illness. And currently for the holidays, we do have that available for a discounted price. So certainly reach out to us at this number that's listed on the slide, and we can help you with that. Another question for Catherine: if the client only has fee-for-service Medicaid, are you able to take the case?
Yes, we are.
Excellent. And then, Catherine, if you want to go back to your slide with your contact information, so it sounds like there are a lot of folks who might be interested in your services, which is great. So you can always reach out to the folks at SPOP at the number on your screen right now. And then if anybody else has questions in terms of resources in other states or cities, feel free to go ahead and give us a call on our helpline. So whether that's, I know there's a question about finding a home care agency or home attendant who deals specifically with individuals who are living with dementia. Our helpline at 866-232-8484 has our licensed social workers available to answer those questions and find you home attendants and home care programs close to you. Also, just a note about our helpline is it's only staffed by licensed social workers. We don't use any volunteers. So anytime you give us a call, you're getting a social worker. We're open 9 to 9 Eastern time, 9 to 1 on Saturdays, so Monday through Friday, 9 to 9, Saturdays, 9 to 1. And starting in February, we'll actually be open on Sundays as well, so you'll be able to get one of our social workers 7 days a week. We're really excited to provide that service to our national care community. So we have one other question or one other comment. Thanks, Carmen. We're glad that you enjoyed this presentation from Catherine. We are so excited, Catherine. Thank you again so much for joining us today. Really just a tremendous wealth of information on such an important topic. And with that, we're going to close our webinar for the day. Thank you so much, everyone, for joining us. Our team here at the Alzheimer's Foundation of America wishes you a very, very happy and healthy holiday season. And we look forward to working with you, whether it's virtually or in person, in 2018. Thank you all again so much. If you're looking for the slides or any other supplemental information, you can get that on the right-hand side. You'll see a panel of where you're typing in questions that say handouts, and you can download the slides from there. If you don't get that or you miss it, you can always email me or call us here, and we can get that to you. Thank you all again so much. Happy holidays.